We have the next speaker now, Dr. Leena Varghese.
So Dr. Leena is an associate professor at Believers Medical College and Hospital. She's a very regular speaker in cataract surgeries, both in state and national conferences. She's also the secretary of, the treasurer of IC18 Kerala chapter and the secretary of the Pathanamthitta Ophthalmic Society. A regular speaker, and we are glad to, a great teacher, we are glad to have you here. And she will be giving the next tip of how to convert from superior. All the incisions we saw in the previous were superior, but it is very important that we shift to temporal, and she will explain to us how and why.
Thank you, Dr. Ashish. At the outset, I'd like to thank the organizing committee, Dr. Ashish, for giving me this great opportunity. I appreciate the efforts of the organizing committee for conducting such a wonderful conference. So good morning all. I'll be talking on making a shift to temporal SICS. So I'll be telling you why, when and where should you think of temporal SICS, how to do temporal SICS, is it really difficult, and what are the disadvantages. Now, when should you do temporal SICS? In senile cataracts where there is an against the rule astigmatism, where you have a steeper horizontal meridia. Now, why do you have to do it? The temporal incision will actually cause a flattening of the horizontal meridia, and the surgically induced astigmatism is comparatively less compared to the superior incision. Why? Because the temporal incision is farther away from the visual axis, and the superior incision, with time, you can have a drag or a gape of the wound due to lid blink and gravity. So because you have lesser astigmatism, you'll have better visual outcome in a temporal incision. There are many studies that have proved that superior SICS has more surgically induced astigmatism compared to temporal incision. You see that in superior incision you get against the rule astigmatism, while in temporal incision you get with the rule astigmatism. There are studies mainly by Sharma et al. Where they found that the post-op astigmatism, 1 month post-op astigmatism, is almost comparable in both temporal SICS as well as in phaco. You have a better approach in a small and deep set eyes. That is, you have more working space. There is no hindering effect of the superior brow when you are doing a temporal incision. It leaves the superior conjunctiva virgin, especially when you are planning a future trabeculectomy, or if you already have a scarred superior conjunctiva, or you have a patient with status post trab bleb. It is easy to convert in case of a temporal phaco or in case of a difficult phaco, such as if you have a rhexis run or rhexis escape, or in case of a AF sign in intumescent cataract, or if you have a very hard cataract, or in presence of any lens subluxation or zonal weakness. You have a better red glow due to the better positioning of the eye. There's no superior rectus suture which is holding the eyeball downward, so you have a better red glow to do your rhexis and other procedures. Now, how to do temporal SICS? Almost all steps are similar. Only few differences are there, of which one is the surgeon has to sit temporal. There is no superior rectus suture. Some surgeons may take a lateral rectus suture. The only thing that you have to remember is when you are taking a superior rectus suture, when you pull the superior rectus, the eyeball turns downwards. While in lateral rectus suture, if you have to turn the eyeball nasally, you have to pull the lateral rectus suture nasally. Now, this is a temporal SICS video. So, conjunctival peritomy is done, hemostasis is achieved. You make side ports like in superior SICS. Inject dye so that you have a better capsule visibility and it reduces capsule elasticity. A large rhexis is done because this is a hard cataract. Sorry. Yeah, just play it, no? Yeah, thank you. A large rhexis is done so that you can take out the nucleus easily into the anterior chamber. Yeah, and then you prolapse the nucleus. Yeah. So when you make an incision in a temporal SICS, make sure that you have a large incision, especially if your cataract is hard. When you make the sclerocorneal tunnel, you need to have the corneal tunnel a little more than the superior SICS. When you're using the crescent, go a little more into the cornea. so that you have a better self-sealing tunnel post-op. You should have good scleral pockets so that you can engage a large nucleus. Like the other speaker said, you have to be very careful when you're doing your incision, especially when it is temporal. You need to have a very good self-sealing tunnel. Make really good scleral pockets. Enter into the anterior chamber with a sharp keratome. Make sure you open up the whole of the tunnel. You can hydroprolapse the nucleus, or you can use a double dialer technique after doing a hydrodissection, after making sure all the cortical capsular adhesions are released. Take the nucleus into the anterior chamber with the help of a dialer. Inject viscoelastic above and below the nucleus so that you do not damage the endothelium. Now when you take out the nucleus, you can use a second instrument like a dialer or a repositor in your side port to take out the nucleus. Wash off all the cortex. Inject viscoelastic and put in the IOL into the bag. After washing out all the visco, you can hydrate the side ports and make sure that you appose the conjunctiva well. Now, what are the difficulties that we face in temporal SICS? One is there is no forehead support for the surgeon's hand. The other thing is there is no superior rectus suture providing a counter traction during nucleus delivery. So what you can do is you can either have a sandwich method. I'll just show it again. You can either have a sandwich method where you sandwich the nucleus between your irrigating. Could you please put back that slide? Sorry. Yeah. Next, yeah. Thank you. Yeah. So you can. Yeah. So you can do a phaco sandwich where you use a irrigating vectors below the nucleus and a dialer on top, or a cystotome on top, and take out the nucleus. Or like I had shown in the previous video, you can use a second instrument providing counter traction while you're delivering the nucleus out through the tunnel. Make sure that you have an adequately sized tunnel and you inject viscoelastic above and below the nucleus. Now, what are the disadvantages? It is said to be more OT time consuming just because you have a difficult surgeon positioning. You can actually compensate that by posting all your right eyes together followed by your left eyes. A superior incision, you may have a better safety because it is covered and protected by lids and it is out of patient's reach. But if you have a very good self-sealing temporal tunnel and it is well apposed with conjunctiva, it is equally safe. It has a slightly steeper learning curve and it should never be done with the rule astigmatism. So these are my references. So the take-home message is mainly that you'll have a slightly difficult nucleus delivery. So for that you need to either have a second instrument and always plan a temporal SICS in case of against the rule astigmatism. These are my acknowledgements. Thank you.
Thank you, Dr. Leena, for that wonderful, clear this thing on the temporal section.